and I've been asked to say just a few words about public health. And I took out my textbooks in medicine, Cecil's, and one of the very new ones, the American College of Physicians textbooks in medicine. And you know what? There was not a chapter on public health in those textbooks. And for some strange, bizarre reason, public health and the School of Medicine in many institutions have gone separate pathways, and that's probably a shame. So you guys' job is to help bring it together again. But the World Health Organization says that public health is the science and art of preventing disease, prolonging life, and promoting health through organized efforts of society. And I just want folks to keep the following words in mind as you listen to our speakers tonight. Epidemiology is the study of populations and disease risk factors and influences of those risk factors on those populations. And public health talks a lot about the following three entities: prevention, avoidance, and protection. And they overlap, but let's take a common example, although maybe a little outside of our frame of reference in King County, Washington, and that's malaria. Malaria affects perhaps 300 million people throughout the world and is responsible for 1 million human deaths a year, minimal. And if you thought about prevention from a public health point of view, it might mean draining swamps and preventing the very replication of the mosquitoes who carry the malaria parasite and transmit it to humans. In terms of avoidance, is if you're traveling to a malaria-infested area, is to avoid mosquito bites with insect repellent and being careful at early dusk and dawn where the mosquitoes are out, and wearing nets around your sleeping quarters. So that would be avoidance. And then protection means even if you got bit by a malaria-carrying parasite, we have medications that you can take before and after and during travel to help prevent the disease from manifesting. So you got an idea? They overlap, but they're different concepts. And in medicine, we have quite a few ethical principles, and two of them were inadvertently deleted from the slide, but one is beneficence, which means to do good. One is non-maleficence, which means to avoid doing bad. So if you can't do good, at least don't do bad. And then we talk about justice, truthfulness, autonomy, and doing no harm. And I want to emphasize that they all have a role. But when we're caring for individual patients, we have tended to emphasize autonomy in our Western culture, a person's right to self-determination. But when it comes to public health, and I may have this wrong and you guys correct me, it flip-flops a little bit. Now autonomy takes a little bit of a back burner, and justice and fairness and beneficence take a primary role. So that, yes, I could do whatever I want, perhaps, but not if it endangers the life of somebody in my community. And public health is there to square up the odds for the people who can't speak for themselves. So with that in mind, I want to introduce Dr. Jeff Duchin, is Associate Professor of Medicine, Allergy and Infectious Diseases within the University of Washington School of Medicine. And he's an adjunct professor, Epidemiology, UW School of Public Health and Community Medicine. He is the chief of the Public Health Seattle and King County Communicable Disease Control, Epidemiology and Immunization section. If you had that on your shirt, it would look awesome. Dr. Duchin handles all epidemiology, communicable disease, immunization, and bioterrorism-related issues in our community. Through 1998, he was one of the lead investigators in the United States Centers for Disease Control and Prevention, and he was involved in investigations of drug-resistant streptococcal pneumoniae, the leading cause of community-acquired pneumonias, Legionnaire's disease, psittacosis, which is an infection you can get from birds, non-tuberculosis mycobacterial infections. So there are quite a few mycobacterial species out there that are not the tuberculosis-causing mycobacterium, and Hantavirus pulmonary syndrome. He is Seattle and King County's top infectious disease doctor, leading the preventive response to infectious disease threats in our area. And I've had some email communications with Dr. Duchin, and I have to tell you that a number of years ago, he put all of the emergency departments in our area on a website so that if there's an outbreak of anything in our area, all of us know about it. And And what it does for us is it makes us awake, alert, and aware. So if someone acquired measles on a plane trip from the Midwest and landed in SeaTac, all of the emergency department doctors know about it. If there's an outbreak of meningitis in the area, we know about it right away. We don't have to wait to discover it ourselves. When there are 2 young kids in the King County area who recently died of complications of influenza, we know about it. And thank you, Jeff. I can't tell you how helpful. I don't read a lot of emails, but yours I do read. Dr. Duchin received his MD from Rutgers University in New Jersey. He completed his internal medicine residency at Thomas Jefferson University Hospital and an emergency medicine fellowship at the Hospital of the University of Pennsylvania in Philadelphia. And he completed subspecialty training in infectious diseases here at the University of Washington. So without further ado, you guys, would you please welcome to the stage Dr. Duchin.
Thank you, Terry. Good evening. It's a pleasure to be here. Thank you for that warm introduction. And I look forward to sharing with you a little bit of a potpourri about what we do at King County Public Health. And as Terry mentioned, I work in the communicable disease program, and I'll share with you a little bit about that. For some of you who, many of you may know this, but for some of you who don't, King County is quite a diverse county. We have the very urban western part of the county, and then also some very rural areas in the eastern part of the county, and our population now is about 1.8 million, which is about 30% of the population of the state. And I just want to start off, Terry mentioned a little bit about surveillance. Surveillance really is the heart of what we do in public health, and many of you may not realize that there are conditions that are legally notifiable to the public health departments across the state, in Washington state, and I'm just showing you the ones that are immediately reportable by healthcare providers and healthcare facilities to public health. And you'll see things in there like acute infections, some serious things like botulism, foodborne illnesses and clusters of suspected food or waterborne illnesses, E. coli infection. We have a category in Washington state called rare diseases of public health significance. That might be something like avian influenza, which nobody anticipated to put on the list. That's legally reportable. But under that type of category, we can request those reports from our colleagues in the clinical facilities, and just wanted to share with you some of the types of things that we routinely do. And so these are some of the more serious ones, and that's reflected in the fact that they're immediately reportable. I'm going to start off talking a little bit about influenza season, because we're in it now, and it was a very remarkable season for all of us here locally. As you know, we had 3 influenza-associated pediatric deaths. These are 2 articles from the Seattle Times. Officials confirm flu killed Seattle 8-year-old and girl 7 with flu dies. 300 out sick. High school closes. So influenza is an annual challenge for us. And Terry said, there's things we grapple with. This is something we grapple with over and over again. And it's a shame because it's a preventable disease. And I'll talk more about that in a minute. This is a national surveillance map that's put together by the Centers for Disease Control. And the red states, this is from last week, the red states are ones with widespread influenza activity currently. The blue states have regional, which is the next highest level. And you can see that right now across the U.S., influenza at very, very high levels throughout the country. Now this is our local data, one of our local monitors. We do surveillance monitoring through a variety of different ways in the county to try and understand how much flu is happening in our area, when is it hit, when is it peaking, when is it going away. And we track the numbers of specimens that are submitted to area healthcare providers, which is the blue line. And you can see that it takes off pretty much the end of January, beginning of February this year, and peaks in late February. And then the red line are the influenza A isolates, the actual viruses that are grown from those samples and by our public health laboratory. So you can see that we peaked at the end of January, and this last week we've seen a little bit of a decline. Now we also do monitoring. Terry mentioned emergency departments. We've set up a novel system a couple of years ago to track all visits to the 19 emergency departments in King County. And you can see here going back to 2000 up through 2006, the type of data that we monitor, and the levels of these peaks and troughs represent the people who are coming into emergency departments with ILI, which is influenza-like illness, fever and cough. And you can see that each time, in the middle of those years, 2003, 2004, right around the turn of the year, that's where you see the January, February peaks, and you can see that 2003 year, very high. That's where we had record-breaking number of pediatric deaths due to influenza in the U.S., 153 deaths during that season, and that's the 0 to 5 year age group, that purple line at the top. So influenza is a disease that preferentially affects the young children and adults over 65 years, and this graph that you're looking at is the trend lines for the various age groups that we monitor to understand the impact that the disease is having. And this is also another graph that reflects data, national data, but also we have this type of data locally, where by week, some of those viruses that we isolate from local residents get studied to understand what type of influenza virus it is. So there are 3 types of influenza viruses that circulate around the world each year, 2 type A and 1 type B, and that's why our vaccines contain 3 types of influenza viruses. And what this graph shows us are the proportions of those different types that are being isolated by the Centers for Disease Control and Prevention in Atlanta. So the type A are the blue and the red on the top, and then that large yellow bar are type A, but the blue and the red are the 2 types that have been identified as an H3 and an H1, and the yellow ones are the ones they haven't tested yet. And then the green ones down at the bottom are the type B influenza. So you can see they're all 3 circulating each season, and that's why you sometimes will see a peak of influenza in the beginning of the season, and then another wave of influenza coming through later in the season, because there are 2 different viruses that are circulating, both influenza viruses, but different strains. Now, this is the mortality curve for the country, and we also monitor this data locally through our vital statistics office. And what you can see, again, are these seasonal peaks and troughs, so the wintertime peak in influenza activity. And the 2 black lines represent what's called the epidemic threshold. Basically, when the number of cases exceeds the level that that line indicates, we're seeing more than we would expect. And so sometimes in the influenza season, we see many more cases of death due to influenza than we would expect to see, and those are the bad years. And again, 2003-04 was a particularly bad one recently. But this year, despite the fact that we had 3 influenza-associated deaths in our county, and we had large numbers of absenteeism, record-breaking numbers of schools reporting high levels of absenteeism this year, the level of hospitalization for severe illness and the levels of death are not higher than we typically see. As a matter of fact, they're at the same level or even a little bit lower than the past 3 years. And here's the pediatric hospitalization data. And again, you're looking at the different lines represent different years. So the blue line, where the high number of pediatric hospitalizations, represents that 2003 season, and our current season is the red line. And you can see again that on a national level, even though we were having a very, very hard time here with 3 deaths, the number of pediatric hospitalizations is relatively low for influenza seasons as they go. Now, when we had our pediatric deaths, it reminded me of an investigation that I was fortunate enough to be able to take part in when I worked in Atlanta, and that was the original Hantavirus Outbreak, which wasn't known to be hantavirus at the time, in the Four Corners region of the American Southwest in 1993. And in the week that transpired between the time I arrived, which was in response to 6 or 8 young, healthy people who died of an overwhelming, rapidly progressive pneumonia, and the time that the CDC lab discovered that this was due to a hantavirus infection, there was a lot of fear, anxiety, and panic in the community. These are the types of questions people asked, and these were the same questions that people were asking us last month when we had 3 deaths, a very unusual phenomenon here due to influenza. Is there something unusual going on? Are we safe? How do we know? And we asked that question of ourselves, and we wanted to determine whether the influenza strains were unusual, whether they represented a new type of flu, whether they represented something unusual about the people who were infected. And we worked with colleagues at CDC, and we sent them specimens from the cases. And in fact, they isolated run-of-the-mill influenza from these cases, from their respiratory tract and from the different organs that the virus infects. And they characterized it as the same strain of influenza that was circulating nationally. So we weren't seeing any weird mutant strain of the virus, although that is something that people wonder about when you have unexpected deaths. In response to these deaths, though, we did get a surge in interest in the flu vaccine. People suddenly realized that and remembered that this is a preventable disease, and it does do some really bad things each year. And so thousands of people were immunized over the President's Day weekend at clinics that our department hosted in North and South Seattle. And I know that some healthcare providers around the town opened up their doors and gave influenza vaccine in response to that public interest in vaccine. Deaths boost awareness of potential threat. I'm going to move on and talk a little bit about West Nile virus. This is a disease that we've been talking about for many years, but I just made a wager today that this is going to be our year. I've done that for the past 3 years, but I think this year, we're going to have some action. This is the national map, and you can see that the disease now has spread from its original introduction in the New York City area, basically across the country. The purple states are states that have had human cases of West Nile virus disease, and the light blue are states that have had avian, animal, or mosquito infections. And you can see we've had 3 human cases this past summer, and I'll show you more about that. But look at Idaho, 984 cases. That was last year. So this is last year's cases. And Oregon had 69, California 276. So we're surrounded. Now, if you look at the number of West Nile cases in humans from 1999 through 2006, that first year it was introduced in New York City. You can see relatively small number of deaths, 18, small number of diseases. The column on your left shows the total number of cases, but there's different types of West Nile virus disease. Most of it is asymptomatic, so people become infected and never know they've been infected. Then the next most frequent manifestation is a mild flu-like illness where you wouldn't be able to distinguish it from any other influenza-like illness that you might have. And then there's something severe called neuroinvasive disease, which is why the disease is of public health significance. The virus invades the brain, and it causes some very serious dysfunction, which can lead to paralysis, seizures, and inability to think and move. And unfortunately, many of the patients that have the neuroinvasive disease don't recover fully, even after many, many months. But as you can see, the number of cases has leveled off at approximately 2,000 to 4,000 per year in the US, and the death toll is in the hundreds each year. Now, West Nile virus, like influenza in some ways, is both more common and more severe in people over 50 years of age. And what this graph shows you are the number of cases and the rate of diseases in the various age groups. And this is based on the first outbreak in New York City, but this has held up over subsequent years. So you can see that in the 0 to 20, 21 to 29, and so on, up to 50, the rate of disease is relatively stable. But once you get over 50, the rate of disease and number of cases goes up dramatically. So it's a disease that is disproportionately affecting people over 50 years of age. Now, in Washington, what's been going on? Well, in 2002, we had some birds, a couple of birds positive for West Nile virus in Snohomish and Pierce, Thurston, and Pend Oreille counties, and then a couple of horses in Whatcom and Island counties. And then 2003 and 2004, you can see the numbers of horses, birds, chickens, and mosquito pools that were tested for West Nile virus, and none was found. In 2005, again, we had a very small number of cases in animals, but last year, for the first time, we had 3 human cases. Now, if you look at West Nile virus positive cases in Washington by county, you can see here that very, very small numbers. Don't worry about the alert levels. That really is for the public health people to pay attention to in the context of mosquito control. But in 2006, no mosquito pools positive. A couple of birds, 13 birds, 6 horses, and 3 humans. So we definitely have this disease in the bird population in the state. It circulates from bird to mosquito, bird to mosquito, bird to mosquito, and once in a while a human gets in the middle of that, and that's when you have human disease. And these are the counties where the virus was documented last year. Here's what I think is interesting and why I bet somebody a beer today that we're going to see West Nile virus this season. If you look at 2004, this is Idaho, Washington, and Oregon. Idaho and Oregon had activity but only 3 human cases in Idaho. So they had some animal, bird, horse cases and so on. In 2005, Idaho had 13 human cases, but in 2006, it just exploded with 900 cases. So this has been the pattern across the country. The initial year, you see a few cases. Maybe there's another year where you have a relatively small number, and then you have a big year. And so I'm betting that we're going to have our big year either this year or next year. But we do have one thing going in our favor here, and that's traditionally the type of disease that West Nile is, which is called an arbovirus disease, which depends on mosquitoes to transmit it from some animal reservoir in the environment to humans, have not been very common and not been seen at high levels for some reason. They don't like something about our environment. So if we're lucky, we're not going to have lots of West Nile virus for many years as a stable long-term phenomenon, but I think we'll have our big year. Now again, back to surveillance, because it's really what public health is all about. And I want to show you this because it's fascinating, and I never get tired of looking at this slide, which was given to me by Marcy Layton, who has my job in New York City. And what this bar graph shows is the timeline of the initial cases that appeared in New York City before this disease was recognized in the US. And what happened was each of these bars represents a case that was hospitalized in a New York City hospital. And you can see that beginning on the 8th of August, 1, 2, 3, then 2 more cases were hospitalized. 1 case of meningitis was reported to the health department. Another case was hospitalized. Another case was reported. And then a whole bunch more cases occurred. So, large number of cases were in the hospitals, but only a small number were reported. And what that led to was a delay in recognition that there was an outbreak of a never before seen new viral infection in the United States. And you can see the epidemiological investigation wasn't started until 2 to 3 weeks after the initial cluster of cases were first hospitalized. So it emphasizes to me the importance of having good relationships with our physicians, our healthcare facilities in the community, having them understand very clearly the importance of reporting to us those conditions on the notifiable disease list, which I shared with you, and understanding that if they see anything unusual, that disease of potential public health significance, even if you don't know what it is, if it's something unusual, it's a good idea to call in and talk about it a little bit. Now, one of the things that I'm doing now that I never thought I'd be doing when I went into public health or infectious diseases was doing a lot of work that somehow or other relates to bioterrorism. And as you know, we had the anthrax attacks in the US in 2001, and that sort of changed a lot of what people in public health do, particularly those of us in communicable diseases, because bioterrorism has become a very real threat. Now, some of you may know that a couple of years ago, before the invasion of Iraq, there was a lot of concern about smallpox possibly being used as a biological weapon. And across the country, including here in King County, we immunized healthcare providers who would be first responders in the case of a smallpox attack and in case a possible smallpox patient came to their facility, they would be protected through the smallpox vaccine and could examine and evaluate that patient and be the first line of defense. So one of the things that we did here in local public health is work very closely with our hospitals and the staffs to have them understand the significant risks associated with the smallpox vaccine, which is a live virus vaccine, which can cause some significant side effects, to understand who among their staff are the most appropriate to get this vaccine, and to do that safely. So that was something a little bit unusual. And we did actually a lot of that work over at Children's Hospital. SARS, another emerging public health threat that jumped out of its animal reservoir in China, most likely in 2003. And even here in King County, we had 60 cases that we investigated very intensively. About a dozen of those were subsequently confirmed as meeting one level of the CDC's case definition, but we had no laboratory confirmed cases. But these new emerging type of infections are something that we find ourselves paying more and more attention to each year. And this is an outbreak of monkeypox that occurred in 2003 in the Midwest, Illinois, Indiana, Kansas, and Missouri. This is a smallpox-like virus that was transmitted from these illegal pocket pets that people were buying at flea markets and other sort of underground animal vendors. And this causes a very, very severe disease with fever and headache and debilitation. These patients were hospitalized and developed these pox-like lesions on their hands that can resemble smallpox. But I can tell you that in the community where these cases occurred, they had trouble finding physicians who would take care of the patients because they thought they might have smallpox. And it was very, very difficult for these people to get the type of medical care that they would get ordinarily if they had a disease that was recognized and to which the physicians had some degree of comfort. So, I've talked a little bit about bioterrorism and emerging diseases, and, we spend a lot of time trying to prepare our healthcare community to respond to a potential biological attack. So I thought this was an interesting slide to share with you. There was a survey done and published in the Journal of Health Affairs where physicians from the American Medical Association master file were surveyed and asked about how well prepared they or their facility were to respond to a bioterrorist attack. And only 20% of the respondents thought they were well prepared to play a role in handling a bioterrorist attack, and only 20% thought their hospital or clinic site was well prepared. So this gives you some indication of why we're spending so much time focusing on these issues now, trying to work with clinicians at all levels, from the small single practice clinic to the large hospitals, and trying to understand some of these unusual agents, how they're transmitted, how to treat them, how to prevent them, and how to report and communicate about them, where to get information if they think they see something. So these are the kinds of things that we do in the context of preparing for biological emergencies. They may be intentional things like bioterrorist attacks, but they may be unintentional things like SARS, West Nile virus, or monkeypox, and they involve knowing who's in charge in a medical facility or a medical setting, just standard command and control. Those of you who have been in the military understand this. Surveillance, how do you recognize and report cases, particularly if it's something new that you're unfamiliar with? Where do you get the information about what to look for? Case and contact management. What treatment do you give the person who's ill, and what advice or preventive treatment do you give the others who've been exposed to that person, family members or other people in the community? Infection control measures are very critical. As a matter of fact, for SARS and for pandemic influenza, infection control measures are really the only thing we have. And for SARS, it was perfectly adequate to take that virus and push it totally back into the animal population and eliminate it from humans. There are no more human cases of SARS anywhere in the world, using only infection control measures, no treatment, no vaccine. Laboratory diagnosis and special procedures. Many of these new agents require special types of testing, and it's important to know where to get that testing in the community. You can't just send it to your routine outpatient clinical referral lab. And then what to do in healthcare facilities and things in the community, which I'll talk a little bit more about in the context of pandemic influenza, but community containment measures. How do you stop the spread of an infectious disease in the community, possibly through isolation, possibly through quarantine, and when those are appropriate to use and when not. And then, of course, communication. Where do you get information during a health emergency? Where do your physicians get information during a health emergency? And how do you communicate back your needs? Now I'm going to switch gears totally and talk about another great public health topic. Human papillomavirus is the leading cause of cervical cancer. And in the US, about 20 million people are infected with this virus currently, and 50 to 75% with high-risk types. So it's a very common infection. And about 80% of women will acquire a human papillomavirus infection by the age of 50. Now, not all of those will be the cancer-causing type, but it gives you some idea of how easily spread this infection is and how prevalent it is, how common. And we know that about 9 million sexually active adolescents and young adults between 15 and 24 years of age are infected with HPV right now. The American Cancer Society estimates that about almost 10,000 women in the US will be diagnosed with cervical cancer, and 3,700 will die of the disease in 2006, about 60 of those in Washington state. So the direct cost of this disease, both because of the cancer, but also because of the abnormal Pap tests and the follow-up for those Pap tests and the diagnostic tests that must be done to evaluate an abnormal Pap test, those associated costs make this a very, very expensive disease as well. So because of all this, a new vaccine was developed after many years of research. And in 2006, last summer, the CDC's Advisory Committee on Immunization Practices recommended that vaccine be routinely administered to girls between 9 and 12 years of age, and for all females who wish to receive it between 13 and 26 years of age. And the vaccine is administered in 3 doses, first visit, then at 2 months, then at 6 months. The vaccine is made from a novel virus-like particles. It's not an infectious agent. The vaccine does not contain a virus. It contains basically a shell that looks exactly like the real virus. So the body recognizes that shell, produces antibodies against that shell, and if the body ever sees the real virus, it kills it before it can establish infection. And this is probably one of the most effective, if not the most effective vaccines that's ever been demonstrated in clinical trials. It's showing efficacy rates against cancer and precancerous lesions in the 97 to 100% range. Very high. It's also been studied in more people than any vaccine has previously been studied at the time of licensure. This vaccine does not, however, do anything about an existing HPV infection. So if a woman has already been infected with the type of HPV that the vaccine protects against, it won't have any effect on that infection. It may prevent, in a woman who has an HPV infection with a different type, her acquiring the cancer-causing type if she hasn't already had it. So no matter what age you are, if you're still sexually active, it may be reasonable at some point in the future to get immunized with one of these vaccines. But currently, it's only recommended up to age 26. So, great. This is a cancer-curing vaccine. Many people think it's the first cancer-curing vaccine, but it's not, or cancer-preventing. It's actually the second. Does anybody know what the first one was? Hepatitis B. Hepatitis B virus, major #1 cause of liver cancer in the world, and that vaccine is the first cancer-preventing vaccine. This is the second. But it's very expensive. $360 makes it one of the most expensive vaccines that's ever come out. And the cost to the Universal Childhood Immunization Program in Washington is going to be about $8 million a year just in its first year. So that's a real implementation challenge. It's also a challenge in that many people don't understand what HPV is. They don't understand how prevalent it is. They don't understand necessarily how easily it's acquired and how common it is. And they don't understand the connection between HPV, the virus, and cervical cancer. So until people make that connection, they may not have a lot of motivation to get immunized with this vaccine, or to get their children immunized is more like it. And then finally, there's always a little bit of a time lag between the time a vaccine becomes available and licensed and the time that we can get the funding together in Washington State to make that available to all of our children. We don't have any program to make vaccine available to adults over 18 years of age. So although our children get it free, if you're an adult and you can't afford a $360 vaccine, you probably won't get it. And then, of course, adolescents are a challenging population to do anything with, let alone get them to go to a physician 3 times over a period of 6 months to get immunized. That's not going to be easy to do. And of course, the issues around socioeconomic status and access to health care and the cost present some very, very significant obstacles. There's been a lot of talk about making this a school entry requirement. You've probably read in the media about the mandate issue. Should it be required or shouldn't it be required? And so I want to share with you a little bit about how that works. But the New York Times sort of decided they were going to make policy about vaccine. There's a new field of expertise. They decided this is a necessary vaccine. And they say debate over a new vaccine to prevent cervical cancer and genital warts has reached a high pitch. State legislators are debating whether to mandate the vaccine or insist its use be kept voluntary. State legislatures should require that all young girls be given this vaccine, which protects against 10,000 new cases of cervical cancer in the U.S. each year and 3,700 cancer deaths. Well, they're not really in the mainstream of public health thought on that, and I'll talk more maybe during the Q&A. But in Washington State, there is a process that's governed by the State Board of Health on what vaccines are going to be legally required for school entry. And the State Board of Health has authority to establish rules for immunization of children for attendance at every public and private school and licensed daycare. And there's the WAC, the Washington Administrative Code, where that authority is granted. And parents in Washington State are given the option to opt out of mandates for medical, religious, or philosophical reasons. Now, many people think you shouldn't be able to opt out for philosophical reasons, but in Washington State, you can. And so when a new vaccine is brought to market that's going to be recommended, the State Board of Health now will wait 2 years after the vaccine has been made available to Washington State healthcare providers. And at that time, they will assess the uptake of the vaccine, the safety of the vaccine, and the need for mandating the vaccine. If there's a compelling need to do that earlier, they have the right to forego the waiting period and establish a mandate earlier. So I will wrap up talking about pandemic influenza, because this is really something that I spend a lot of time thinking about, and you should too. The pandemic of 1918-19 killed more humans than any other disease in a period of similar duration in the history of the world. And these are the mortality curves for New York, London, Paris, and Berlin during that outbreak. And you can see that 1918, this giant wave of mortality simultaneously in many of the large cities around the world. And if you look at trends in infectious disease mortality in the US during the 20th century, there's a great decline with onsets of improvements in public health measures such as vaccination, good hygiene in the water and food, and the notable exception is this giant spike here with the 1918 influenza pandemic, which shortened the lifespan dramatically in the US. And this is a headline from 1918, 6 million deaths from influenza. This is the estimate for the world for the past 12 weeks. Recalls the Black Death, 5 times deadlier than the World War. Now, what does all this mean, for us? It's chickens. There's nothing more determined than poultry with a plan. So why am I telling you about 1918? Who cares? It's the chickens. So avian flu, a large, unprecedented in magnitude global outbreak of bird flu that started in Southeast Asia has now spread to all these countries since 2003. And you can look at, again, all these different colors each represent a country where human avian flu cases have occurred. And the mortality rate here is about half the cases have died. And you can see these peaks also are seasonal. Because of this large outbreak in birds, and because that's been shown to be able to infect and kill humans, the World Health Organization has indicated that the world is at stage 3 of their pandemic alert scheme, which means there's a new influenza virus that's causing disease in humans, but is not yet spreading efficiently and sustainably among humans. The US has developed a pandemic severity illness to help us guide how we would respond to a new pandemic, and that severity index is based on the case fatality ratio, the number of proportion of people who die, who become infected, and you can see the range of deaths in the US population that the various categories would result in. I just want to focus on category 5, which would be the 4 and 5 would be really the 1918 style, where you'd have over 1 million deaths, so maybe over 2 million in the US alone. In King County, we've done some estimating to show that with an attack rate of 35%, meaning about 35% of people become infected, which is what you would expect in a pandemic, we might see between 800 and 1,100 deaths, between 250,000 and 500,000 excess outpatient medical visits, and between 24,000 and almost 60,000 excess hospitalizations. Now, we only have about 3,000 staffed hospital beds in the county, so immediately you can see some of the challenges that we're dealing with in planning for something like this. There is some federal guidance to help state and local jurisdictions plan. There's a HHS, Health and Human Services Pandemic Plan, and there's a national strategy for pandemic planning, and I tried to sum them both up in one slide for you, and this is it. Any community that fails to prepare with the expectation the federal government will come to the rescue will be tragically wrong. That was said by our Health and Human Services Secretary, Michael O. Levitt, not known for being much of an exaggerator or histrionic person. In our measures to control spread of transmission in the community, which were just published last month by the CDC, we're finding the same thing that was in the newspaper in 1918. Churches, schools, and shows closed. So a lot of the same things that were done in 1918 are going to be done again, but hopefully they'll be done in a more coordinated and earlier manner. I'm going to stop here with this. I really appreciate you squeezing me in this afternoon, Doctor. I'm a terrible panic every year until after I've had my flu shot. I hope you've had yours. And finally, I want to try to answer the question, who's protecting the public health? Since this is the mini medical school, I thought who would be better to protect the public health than mini me. So, thank you very much. I'm happy to take your questions. Thank you.